Tom Lüscher, and this is Inside Cardiology. Today we discuss evidence. What is evidence and how good it has to be? When we ask a dictionary, of course we get the following answers. The availability of body of facts or information indicating whether a belief or proposition is true or valid. This is what we want in medicine. What a proposition is, a statement or assertion that expresses a judgment or opinion. We don't want actually an opinion. We'd rather would like to be confident that this is actually a statement of fact and not a belief. So this is the first thing, and when we look at what evidence we have in medicine, we have registries, we have Mendelian randomization studies, we have randomized trials, and we have meta-analysis of both the Mendelian randomization and randomized trials. Now, registries are associative in nature. They cannot prove causality, but they can be a very good basis for further evidence. For instance, as you know well, the Framingham study has established all the risk factors such as age, cholesterol, sugar, blood pressure, and the like. And particularly for lipids, which was pretty controversial initially, they basically set the stage for a seminal trial, the 4S trial, that then showed lowering cholesterol is indeed reducing events. So it's not just a risk factor, it's a causality. So registries are important, but their evidence is limited to really real-world data that are more associative in nature than proof. Then, of course, Mendelian randomization. This is actually a randomized trial, if you wish, using genetic information. And genetic information can be a mutation. For instance, a mutation in a gene that codes for LDL, like PCSK9. Now, if you have a missense mutation, then of course you have a huge reduction in the event rate in these Afro-Americans that are carriers of this mutation. You have an 88% reduction in events because it starts from childhood. And so this was the basis to test actually whether PCSK9 inhibitors would reduce events, and sure enough, this was confirmed in a randomized trial. So Mendelian randomizations are really solid evidence, but still in medicine we want to show that really a medication that mimics this genetic mutation would be effective as well. Now, how good does the evidence have to be? And here we will have a paper that's just about to be published in the European Heart Journal, the 2024 revision of the level of evidence grading system for ESC clinical practice guideline recommendations. This is a very important document because it makes the assessment of evidence much more stringent, much more strict, to be really sure that what we talk about is really solid evidence that we can use to manage our patients. And this has been mainly driven by Peter Jüni, Eva Prescott, the former guideline chair, and Colin Bagent from Oxford University. And here are a few things about this. First of all, a randomized trial is the best evidence we can have because it really provides causality. And here we have to look at patient allocation. Is there an adequate concealment of allocation? And then, of course, no major differences in baseline characteristics. Secondly, implementation and adherence. We want to, of course, make sure that there is no deviation from the intended interventions to a more or less degree. That's particularly challenging for device trials, much less for medication trials. The outcome assessment should, of course, be blinded, without influence by knowledge of the interventional received by the participants. So objective outcomes, outcome data should be as complete as possible, and reporting as good as it could be. Then of course we don't want that the evidence is a play of chance. So that comes up with the p-values. And if we look at the Gaussian distribution here and the hazard ratios, we can say the following. For superiority, that is, a trial shows that an intervention is better than usual care or better than placebo, we want a two-sided p-value for superiority, usually equal or lower of p0.05. This is more stringent than in the past, where p0.05 was accepted, because there is still quite a probability that this is a play of chance, this superiority, if it is not documented by more stringent p-value. Non-inferiority, the upper limit of a two-sided and 95% confidence interval, usually excludes a 1.15 for unfavorable outcome on a relative scale. That's shown here on the slide in the Gaussian distribution curve. Then equivalence is two-sided 95% confidence interval, usually excludes 0.787 and 1.15 on a relative scale, that is the hazard ratio. And then harm, point estimate indicates harm, lower limit of two-sided 95% confidence interval excludes 1 for unfavorable outcome on a relative scale, i.e. a hazard ratio in a two-sided p-value of equal or lower than p0.5. Okay, so in the meta-analysis, of course, there are also characteristics suggesting high quality. The study selection, of course, if you include very good quality studies, randomized trials, blinded randomized trials with good data documentation, that is, the study quality is very important, and the study size. Are these very small studies, or are they really big ones that give solid evidence, eventually also in the meta-analysis? And then, of course, we don't want unexplained heterogeneity between trials. Now, the old definitions of level evidence A was data from multiple randomized controlled trials or meta-analysis. Now, the new revised definition says conclusive evidence that benefit exceeds harm, usually from at least 2 adequately powered randomized controlled trials, free of major bias, with substantial evidence against the play of chance when combined in a meta-analysis, i.e. here again a more strict p-value of equal or lower than 0.005 for superiority. Then level evidence B. There is now a separation between level of evidence B1, suggestive evidence that benefit exceeds harm from at least 1 adequately powered randomized controlled trial, free of major bias, with statistically significant results when combined in a meta-analysis with here a p-value of p smaller or equal of 0.05 for superiority. So the p-value really determines the weight of evidence, whether it's A or B1. Now B2 would be limited evidence that benefit exceeds harm from at least 2 adequately powered non-randomized studies with careful control of major sources of bias, like a propensity analysis, and substantial evidence against the play of chance, with a p-value here again stricter of equal or lower 0.005 for superiority. Or from a meta-analysis of small underpowered randomized controlled trials, a situation we have not so rarely, with statistically significant results, IGP 0.05 for superiority. And then of course level evidence. C is, of course, preliminary evidence of small underpowered RCTs, non-randomized studies, or expert opinions. And of course, this is a situation we also don't have so rarely, because not everywhere do we have, particularly for rare diseases, randomized data. Okay, and so we can say that this is more strict for evidence, but as a clinician, I also would like to know whether what is statistically significant, is it also clinically relevant? That means how many patients do I have to treat to see an effect? That is the number needed to treat, NNT. And of course, the lower the better. If I give a statin and after an infarction and I have to treat 30 patients, let's say, that's okay. But if I have an ICD very, very well indicated to the patients that deserve it, and I have an NNT below 10, this would be fantastic. But at the same time, we also need numbers needed to harm to be as high as possible. We recently had a trial where the numbers needed to treat was 8 and the numbers needed to harm were 6. So this is not what we want. We want more separation, really, to be sure that the benefit outweighs harm by far. So with this, I think we are much closer to a more stringent assessment of evidence, and also a separation between very good evidence, excellent evidence, and good evidence or no evidence. This is crucial for the guidelines, of course, because the recommendation have for the physician to have a value. That means that the value of the statement of value that recommendations are based on different levels of evidence, and this, of course, affects massively our decisions to use this or another intervention or drug. So the evidence is a statement of fact, and the level of evidence for such a fact can be A, B1, B2, or C. And recommendations are a statement of value. There is always some judgment involved, and that is why also guideline committees vote on difficult decisions by a vast majority. And here the recommendation class can be 1, 2A, now 2B, or 3, respectively. So I think it is important when you read guidelines that you understand these aspects of how evidence is assessed, what it means for you in clinical practice, and how strict you have to follow the recommendation based on the level of evidence. So I thank you for that, and see you soon in Inside Cardiology.